welcome to this PCR webinar. My name is Patrick Calvert from Cambridge in the United Kingdom. It's my great pleasure today to welcome my co-panelists, Jens Erik Nielsen Kutz from Aarhus. Hi, Jens Erik.
Hi.
And also Olivier Muller from Lausanne in Switzerland. Hi, Olivier.
Hi, Patrick.
So today we have a 60-minute webinar entitled, How Should I Make PFO Closure a Safe and Effective Procedure? We're going to go straight to the learning objectives to tell you the framework on which we will build our webinar today. What are our learning objectives? Well, we want to understand what tests to perform before PFO closure to select the correct patient, to understand how to avoid, identify and treat procedural complications. I'll say that again because it's the key to this: avoid, identify and treat procedural complications, and learn the appropriate post-procedural management and follow-up. What I'd like to do, gentlemen, is start by setting the scene here. Now, we all know that PFO is a common finding. Data would suggest that around a quarter of the adult population have a PFO, and therefore it's absolutely fundamental to selecting the correct patients for closure that we focus very carefully on patient selection. And for me, this means using our friends and colleagues in different specialties such as neurology and stroke medicine to make sure we access the right patients in a format that you might want to call a multidisciplinary team meeting. Jens Erik, we know that patients in the randomized control trials who had a cryptogenic stroke benefited from PFO closure. Would you like to tell me a little bit about what cryptogenic stroke means and how you go about identifying these patients?
Yes, I will. Sure, Patrick. So a cryptogenic stroke is a stroke without a known cause. So speaking about a cryptogenic stroke, we have to rule out other well-defined stroke mechanisms. So we have to rule out atrial fibrillation, carotid artery disease, etc., in order to speak about a cryptogenic stroke. Traditionally, cryptogenic stroke has been grouped, or PFO-related stroke has been grouped together with all forms of cryptogenic stroke. But I think time has come to change our nomenclature now, because we really know that PFO can be a well-defined cause of an ischemic stroke now. So there is a suggestion now to really try to classify and speak about a PFO-associated stroke and leave the term cryptogenic stroke for such cases. And what is really the clinical characteristics of a PFO-related stroke? The typical thing is that it will occur in a young or predominantly young patient. There will typically be a cortical infarction, the localization in the brain, and then there will be absence of risk factors like atrial fibrillation, atherosclerosis, etc. And typically, echo will show a moderate to large shunt, or in many cases, even atrial septal aneurysm.
Jens Erik, that's a really clear description, and thank you. You know, something I find quite tricky, Jens Erik, is when we have patients and they come in with typical symptoms of what we think is a ischemic stroke, but actually when a brain MRI comes along, there's not much signature of a scar on the brain MRI. Some people call this a TIA. How do you approach these patients, and who do you ask for help with this?
Yeah, I think we really need help from our neurology colleagues in such cases, because I think the whole group of TIA events, that is a very complex and broad group of patients. And what my neurologist in my institution always tells me is that if you really need, if you want to classify or talk about a TIA, you really need MRI imaging of the brain to prove that there is ischemic damage. There can be migraine, there can be a lot of other events that can be mistaken for a TIA. So I think MRI imaging here is essential.
No, I think that's a really clear message, Jens Erik. Olivier, Jens Erik talked a little bit about excluding atrial fibrillation, Now, in all the randomized control trials that support PFO closure in PFO or cryptogenic stroke, they said that PFO closure, they said that atrial fibrillation had been excluded. But actually, practically in the clinic setting, what does this mean to you with your patients, and how do you go about excluding atrial fibrillation?
So it's AF. It's a major issue for PFO patient selections, and you have several ways to exclude or at least to seek for atrial fibrillation. The first is when the patient have the stroke. Usually the patient is admitted to a stroke unit, and then you have several hours or days of in-hospital monitoring, cardiac monitoring. So this is the first door that you have to open in order to exclude AF, is the in-hospital monitoring. Then I think PFO closure or PFO stroke due to PFO is something that you have to individualize, meaning that if you have a young patient or old patient, it's very different. So if you have a young patient, the chance to find an AF is lower than if you have an old patient. So if you have a young patient, I will go for an in-hospital monitoring first, and then we perform Holter monitoring during 1 or 2 weeks. Usually, if it's a very young patient, we go for 1 Holter. If it's a middle age, so under 50, we go for 1 or 2 Holter. And then if it's a patient above 50 years old, then we need to seek for atrial fibrillation. This means that you can have an external loop recorder or an implantable loop recorder, which we call ILR. And then I think it worth to seek for AF more deeply if you have a patient over 60 especially.
Well, so Olivier, so that's really clear. So what I think, to summarize what you're saying, is that the risk of atrial fibrillation increases with age, but also with some other factors. And really, we have to use the technology wisely and carefully and tailor it to the patient on, as you say, an individualized basis. You talked a bit about implantable loop recorders. Of course, they were originally with syncope monitors, but clearly now in these days, they've got quite good AF algorithms. Can you tell me a little bit about the pros and cons of detecting atrial fibrillation with a loop recorder as compared to, say, the standard ambulatory ECG?
Yeah, I think the ILR, implantable loop recorder, has a really nice sensitivity. So you will find the AF, but it has some kind of issue with the specificity. If you look at the tracing, actually, there's a lot of artifacts, so it's not very easy to really declare that it's AF. It can be recording from the ventricular signals, so you are not very able to say whether it's extrasystole or premature beat or it's atrial fibrillation. So we have not only to just have the idea of the implantable loop recorder, but we have to look into the data of the implantable loop recorder. When you look into the data, it might be a little bit more confusing than it looks like. So I think that you have to use the ILR in a very specific population where the chance to find AF is higher than normal. Meaning, and I'm coming back to what I was saying, is like if you test the implantable recorder in a population over 60, I think the chance to find it is really higher than below 50. Indeed, there are risk factors associated, but I would say that age is a major risk factor.
So that's great, Olivier. Thank you. Very clear. And I think we have to also mention the really obvious thing about a loop recorder is you can record for a long period of time. And we have some quite good data to suggest that pickup rates are obviously better with the loop recorder. But the problem is you can spend a very long amount of time looking through loop recorders with and I think something that's important for us all to acknowledge, we don't know how long AF is meaningful. There's not, as far as I'm aware, very clear data on how much AF triggers you toward oral anticoagulation. Jens Erik, do you have any comments to make on that?
Yeah, I think that's really an important question, and I totally agree. I mean, is 5 minutes with AF, is that enough for us to trigger anticoagulation treatment? Having a patient totally without symptoms of AF, we don't know that. We don't know if 30 minutes is relevant. I mean, these devices can definitely detect AF and with a high sensitivity, but we don't know yet how to do with our findings, I think.
So thank you for those who've already come online with. I've got some great questions already. Some I'm going to answer now and some I'm going to answer as we go through. Wonderful question about lacunar strokes in young patients with no vascular risk factor as well. That question will be answered in the next 10 minutes. It's part of our approach in our slides. I think it's a really important example. Hello to those in Eastern Europe who are exchanging hellos. Thank you very much. And we have a question. I'll put this to you, Olivier. 45 seconds ago, he texted in to say, what about patients with previous strokes, but for example, being divers? Well, for me, I think, Olivier, maybe I'll answer this myself. The focus of this particular webinar is cryptogenic stroke. There's no substantive data that patients with strokes benefit. No substantive data that patients with PFO and who have divers benefit, but clearly there's lots of problems with registration issues and decompression. So I think that's a little bit outside the remit of this. We're going to focus today on PFO-related strokes. We've had one question, which I'll put to you, Olivier, and then we're going to move on to the next section. What about Apple Watch, which gives you a readout on ECGs? Is that a good way of detecting atrial fibrillation? Difficult question to ask, but I've had people come to me on a number of occasions saying their AF being picked up in the watch. Do you have any comments, or either of you, about the sensitivity and specificity about using these smartwatches for detecting atrial fibrillation?
So we don't have any data regarding the specific population of cryptogenic stroke. So difficult to answer. I would say once you have a recording and a tracing showing AF, it's fantastic because you have it. Now you don't know whether the sensitivity of the watch recorder. So I'm still sticking to our Holter in hospital monitoring and implantable loop recorder instead of watch recording.
I would totally support that, Olivier. And my personal experience of people who've sent those in is I have actually found they tend to be very heavily over-filtered, and often it's really an irregular R-to-R interval is what they're detecting, and the atrial activity is hard to discern. So we're going to move on, Jens Erik. I just want to ask you, we've not talked much about brain imaging yet. Do you want to just say a little bit about brain imaging, what you're looking for in the brain imaging, what kind of brain imaging, and maybe is there anything more than brain imaging you look at from our neurology colleagues?
Yeah, I think that current standard, at least in our institution, we use MRI scan of the brain for all patients with stroke or TIA. So I think that is the state of the art. And you can definitely look for the localization of the ischemic lesions. And typically cardioembolic material will travel with the bloodstream to the brain, and they tend to localize in the cortical areas. So when we see cortical infarcts, we think definitely about cardioembolic stroke. And if there's a history with several strokes, it's also typical that they are in different regions of the brain. On the contrary, if you find ischemic lesions in the deep part of the brains corresponding to the penetrating arteries, it's maybe more likely to be related to atherosclerosis or hypertensive vascular changes, at least to a vascular cause. So this distribution is what we look for. But another important issue is also to look at the vessel, at the neck vessels, because in young patients, one of the more rare causes for stroke is dissection. So also when you do your imaging, it's very nice to have focus on the vascular status, look for dissection in young patients, of course, and also look for major atheromas in order to, get close to an explanation for the underlying mechanism.
That's really clear. Thank you very much. We've had a question from a colleague online asking a young 64-year-old male with ischemic stroke and paroxysmal atrial fibrillation, should they have an appendage occlusion or a PFO closure? Well, I think I can tell you that they should not be having PFO closure if you've detected paroxysmal atrial fibrillation. Whether they go on to have oral anticoagulation or if they have an appendage occlusion depends on other risk factors. Jens Erik is one of the world experts in left atrial appendage occlusion therapy. But I will tease you with that because it's not really in the remit. So we're going to push on, actually, if that's okay. There's been a lot of questions online about specific scenarios and patients. So what I want to do is show a way we go about it with a couple of examples. And Olivier is going to talk to us a little bit about something called the rope score, which I think helps us with our decision-making process. So Olivier, tell us about the rope score.
So the rope score is indeed very helpful, and it can give you the idea that you solved the problem, because it can give you a percentage, and then you can advance in your clinical decision making. I would modulate a little bit the rope score. The rope score is a mathematical algorithm. It is derived from Bayesian statistics, so the prevalence of the disease in the population is very important in the rope score. And then it gives you, and I think you are seeing the slide, a number of variables: hypertension, diabetes, stroke, history of stroke, smoking, and imaging of the brain. And then there is the age. These are all variables that are very important, and I think that you can really clearly see that the age is the most important variable, and we know it without using the rope score that age is very helpful. So I think, to my point of view, it gives you a risk of that the stroke is related to the PFO. So it is written on the slide. So if the rope score is 10, then you have 88 risk that the stroke is due to the PFO, and if it's 0, it's 0. So it helps a lot when you have to discuss with the patient, because you can put a number. If it's 7, it's 72% risk that the stroke is related to the PFO. And then it gives an idea for the patient. Now, you have to keep in mind that there are other parameters that we have to keep in mind in order to take our decision. And also anatomical of the heart, of the atrial septum, is very important. So there are several ways to take the decision, but the rope score is one of the parameters that we can use in order to take the decision.
That's very clear, Olivier. Thank you. So a couple of comments I want to make about the rope score. It is derived from a number of databases on cryptogenic strokes, okay? So you shouldn't be applying the rope score to a patient if there's another explanation for the stroke. So if, for example, there's been a spontaneous carotid dissection or vertebral basilar dissection, or there's atrial fibrillation, you mustn't use that under these circumstances. Those patients should not be having PFO closure. And the reason I like this score is because it does what we do in our own brains. We are building a probability of likelihood that this is PFO related. It is extraordinarily rare that we have certainty. Occasionally in our careers, we'll see clots lodged inside PFOs, and then we know for sure the stroke is related to that. But actually, the smoking gun, as we call it in Britain, is not very commonly seen, and we're building a probability, we're building a case. And I think Olivier mentioned this in the build-up. It also gives your patient something to think about So if you have a rather low rope score, the chances are fairly low that it's PFO related, and then they can understand and get some reassurance. Whereas if it's higher, then certainly you start to get serious about PFO closure. And I think what we're going to do, chaps, here is why don't we just go straight into some cases, and we'll talk about how we apply the rope score to those. And I hope this will answer some of the questions online, because I've had a number of online questions about specific cases. Okay, Jens Erik, we have a 55-year-old male, transient dysarthria, high blood pressure, no other cardiovascular disease risk factors, no focal neurology and clinical examination because it's clinically improved, and monitoring for 72 hours with no arrhythmia. When we look at the echo imaging, it's unremarkable with a suggestion of a PFO. The team in this case didn't do a transthoracic bubble echo, which I have to say is my preferred, most sensitive way. I think it's easier to generate a right to left shunt with a good valsalva release in an awake patient, but they did a PFO, they did a transesophageal echo. They saw typical tunnel PFO with flow reversal and valsalva release, and there's a mobile aneurysmal atrial septum. If we look at the brain imaging here, and this is hopefully will answer one of the questions we've had about lacunar strokes. This is a small lacunar stroke seen on a brain CT. It didn't actually require an MRI scan in the right basal ganglion. I have calculated the rope score here. It's 5 out of 10. He accumulated some figures, but not so many. And he's been penalized somewhat by his age, I think. And the rope score says that it's only a 34% chance that the stroke is due to the PFO. I'm going to go to you, Jens Erik, first of all. What are you going to do with this patient?
I think this is a patient that is 55 years old. He has got some vascular disease. He has got mild hypertension, and the brain imaging shows a lacunar infarct. So there's a lot of arguments that this patient here could have a stroke related to vascular disease. I would, although, also go on and do Holter monitoring. In my institution, we would do Holter monitoring for 1 week to look for atrial fibrillation. There is a history here of hypertension, which increases the risk of this guy having AF. On the other hand, I think we can also definitely not rule out the PFO as a causative mechanism here. He's 55 years, but his only vascular risk factor is mild hypertension. He's on a low dose of ramipril, and his blood pressure is well maintained. And echocardiography actually shows a high-risk PFO anatomy, namely an atrial septum aneurysm. So I think it's very open in this case what is really the underlying mechanism. So I would await first of all, the Holter monitoring for 1 week, whether this guy has AF.
And after 1 week, Jens Erik, it shows no AF. What are you going to do next?
Yeah, I would take a very good discussion with our neurologists whether we should actually try also to eliminate the PFO as a risk factor for a new stroke and offer him PFO closure. I don't know completely what their view will be on this. They might be also positive for PFO closure, and if they are, I would definitely have a good talk with the patient and explain him that this can be due to vascular disease, but it can also be due to the PFO, and try to find out what would be the preference for this patient. So some kind of shared decision making.
So it's not simply just the wonderful Scandinavian diplomacy. I think this is a wonderful example of the fact that this is not a black and white thing. There has to be a discussion with your neurologist, and there has to be a discussion with the patient as well. Olivier, I've had a question online. And I'm going to come to you what you think about this particular case. They want to know, is there a cutoff for the rope score? And if so, what is it?
So the rope score we have a cutoff of 6, and once you are in a score of 7, you have 72% risk that the stroke is related to the PFO, and 6 is, I think it's 50 something. Maybe you can remind me, but we use the cutoff of 6 in order to take not our decision, but to influence our decision, I would say. So this is the answer for the question. And regarding the case, I just want to comment one thing, is that indeed, as was saying Jens Erik, is a middle range person, 55 years old, is really at the limit where everything can be possible. And there is one thing that we should take into account is a lacunar stroke. So lacunar stroke maybe is a little bit against stroke related to the PFO, hypertension as well. But what I want to underline is that to show that to know what to do with the patient with a cryptogenic stroke is a process, and we need to process. And there are very clear cases, and you can see with the ROPE score that you have almost 90% in a young patient, and almost 0 if you have a lot of risk factor. So it's a process, and you have to deal with probability. And this is a patient where you have like a 50% probability, or it's 35 given the ROPE score, but maybe it's a little bit more. And then we have to process, as was saying Jens Erik, with Holter monitoring or implanted loop recorder, but we have to process the clinical decision making.
Great discussion, guys. I really appreciate that. Brings out the process, which is the important point. So let's go to our next case. So that's the conclusion of the first case. So second case, 35-year-old female, right-sided weakness and sensory disturbance without any past medical history, but she is a smoker. She has some residual weakness on the right side, but with controlled blood pressure and 5 days of Holter monitoring showing no arrhythmia. Her echocardiogram's unremarkable, and she's got a moderate right-to-left shunt and valsalva release of transthoracic bubble echo. If we have a look at her brain MRI, we can see here a left cortical infarct, and her ROPE score is very high. Now, I don't think there's a huge amount to say about this case. I think all of us would agree that this is a clear-cut case for PFO-related stroke. The ROPE score also agrees. The reason I've shown you this case is it's important to know what a clear-cut case is so you know what a controversial case is. But I also, and I hope this answers some of our online questions, if we change this case ever so slightly and change the brain imaging such that it is same patient, but actually this time it's a lacunar infarct, then, and it's this time you can see that the ROPE score would suggest to you that actually it's still highly probably likely that the stroke was related to the PFO. And I think, Jens Erik, this goes back to what you talked about 10 minutes ago, is that we are interested in the brain imaging, and it's very important. And there is no doubt a cortical stroke is more likely to be implicated, or the type of stroke in an embolic stroke. But again, it comes to what Olivier was saying, is that it is a process you go through, and it's only one of those things. Any comment on that, Olivier? Yeah,
I think it shows really clearly that the ROPE score is influenced by age. So you are coming from 80% to 70% or 72%, given the fact that you have an imaging, brain imaging, which is cortical or lacunar. But what I'm thinking is that if it's 70% or 84%, it's almost the same, I would say. So it doesn't make a lot of differences based on different brain imaging, because age is really the important variable in the ROPE score. So in this patient, I would, as all patients, go for the process and really look at atherosclerosis, because even if you are young, you can have a lot of risk factor atherosclerosis, familial hypercholesterolemia, or whatever. So I would go through all the process, even though that the patient is young and have a high risk of PFO related stroke, given the ROPE score.
Olivier, thank you very much. So I think we spent an appropriate and correct amount of time on patient selection. If you could just bring up the next slide for us there. This is just a wrap up for patient selection. PFO closure is only proven in cryptogenic stroke. AF must be excluded, and actually this is a judgment, but in older patients with higher risk factors such as hypertension and maybe increased atrial size, ILRs can be very useful to exclude atrial fibrillation. A multidisciplinary team using the expertise of our neurologists and our stroke physicians, in my view, is mandated to help us with those difficult cases, and really in all cases, from my view, from a governance point of view. And I think, for me, I think we've illustrated the utility of the ROPE score and how it can help you, and not only you, but also your patients with decision-making. What I'd like to do now is talk a little bit more about the procedure. We all know that there is a very clear benefit from PFO closure, but the statistical benefit is quite small. And therefore, it's beholden on those people who undertake the procedure to make it an absolutely complication-free procedure. I think we all three of us feel very strongly about that. Now, PFO closure, we all understand, is not a technically demanding procedure. It's not like MitraClip, where there's some technical challenges. However, we should not be asking ourselves, can I do a PFO closure? We should be asking ourselves, have I done everything possible in my power to make this a complication-free procedure? We must avoid, identify, and treat complications. So we're going to spend a little bit of time talking about that. And Olivier, I'm going to come to you first of all. Can you tell me a bit about how you guide your procedure from an imaging point of view? What do you do? And tell me how you think it helps.
Really, it's really important to be safe, as you were saying. And I think to our point of view, we are using the ICE, which is the intracardiac echocardiography, in order to implant the PFO device under supervision of the echo. This is very important. We have several arguments for that. To my point of view, the first is that we are dealing with very young patients, and it can reduce the radiation exposure. This is very important to my point of view. And it offers also the possibility to implant your device with a single operator. You don't need the TEE, you don't need anesthesia, you don't need sedation. You are really like coronary angiography. So I think there are several advantages to use the ICE guidance in order to implant the PFO device. Indeed, the caveat is that it's a little bit expensive, even though for a Swiss guy, I think we have to confess that it's a bit expensive. But if you are using a TEE, so you need an anesthetist, you need a TEE, you need a probe, and I think the salary of an anesthetist can be implanted in the ICE because you can be alone. So there are several advantages to my point of view to use the ICE, and also it can give you a really detailed structure, and you can see everything before and after the implantation in order to see that the device is well implanted. And as you were saying, we have to be really safe. We are dealing with very young patients, and we have to be 100% sure that the device is well implanted.
Well, that's very clear. And I know Jens Erik does agree with that. I know he's a great proponent of the ICE. I mean, I think some of the things we talk about that we would want to identify, you know, thrombus is extremely rare if you heparinize properly and immediately. But actually, if you don't use any kind of echo imaging, you simply won't see it, and then you won't know it's there. And it's so important that we are able to react to it. I think you'll know more about the anatomy. You'll know if you've got a prominent eustachian ridge that might hold your device up, if you've got an extensive Chiari network that might interfere with deployment of the right atrial disc, for example, and also the ability to rapidly identify any complications. Thankfully, in appropriately conducted hands, pericardial effusions are rare, but you want to know straight away. You don't want to be finding out sometime later. So I think it's extremely important to be able to have that information up front. Jens Erik, we're going to talk a little bit now about vascular access. We're going to look at some slides on vascular access. I'm going to show our participants what I would call a beginner's guide to vascular access, and then I'm going to hand on to you for an expert's guide. So if we just move forward with the first slide here. The first thing I want to say is I'm a firm believer in ultrasound-guided access for these, but I would point out that many people who are wedded to the idea of landmark-based puncture and feel very comfortable with this, there's a journey to go through to move to ultrasound. It's not an immediate intuitive thing, I don't think. And these are a number of safety ideas to help you with that journey, to make you safe in your journey to what I think is a gold standard way. The first thing I would encourage you to do would be to screen the femoral head. You can see a clip on the left-hand side, and then you can see it screening the femoral head. Try and put it around the mid-level. This gives you a safety marker. When you're scanning with your ultrasound, you don't want your needle to go in above that, because, of course, if you're above that, it may be that you're unable to compress. The second thing I want to show you, and we'll move to the next slide, is we scan with the ultrasound. Now, you see a schematic of the femoral triangle. If you look at the femoral vein, which is the blue structure running up and down the slide, and you can see another vein joining it, which is a great saphenous vein. What I personally do is I put my ultrasound probe in cross-section at the level of my clip. I know I don't want to scan or puncture any higher than that. Then I bring my ultrasound probe down until I see the great saphenous vein entering. And then I know I don't want to be any lower than that. And then I go up slightly, and that's a puncture point for me. I personally like to pre-close with the ProGlide because I use transesophageal echo, because in the United Kingdom, anesthetists are cheaper than ICE probes. And that's our approach. But if you have two catheters in the same groin, you might have a different approach. And Jens Erik will talk to us a bit about that in a minute. So we're about to play the ultrasound of that. You see on the right-hand side, you can see the artery on the left and you see the vein on the right. And this will be starting at the midfemoral head, drawing the ultrasound probe down till you see the great saphenous vein, and then going back up again. And that's what I do in all these patients. So let's let that play. So there it goes. Draw it down a bit quickly, unfortunately, and then down to the great saphenous vein, and then back up a little bit. And this is where I want my puncture point to be. I draw the vein right into the middle of the screen, and then I focus all my efforts on holding it completely still. It's playing again, back down the correct saphenous. And if we stop it there, that's where we want it to stop, and that's where my puncture is going to be. Then if we move forward one, I want to show you, if you're going to adopt this style of cross-sectional approach, then you want your needle to be steep. And the reason for this is that if it's not steep, you might mistake the shaft of your needle for the tip of your needle. You need to know that you are indenting the anterior wall of the vein with the tip of your needle, and you want to know at what height you're at. So if we play this, and then you can see that we're pushing on the front wall of the vein with the needle. You can see the tip of the needle. There you go. It's pushing, and then as it releases, it's going through. Maybe if we play that one more time, so you can see it, and you see pushing on the front, and then it gives and it goes in. If we go to the next slide, then I also scan backwards and forwards. Here you can see the femoral head, so you know what height you're at, and you see the wire going in, and that's scanning over to the artery and back to the vein. And we just go, we missed the slide on it, but we pre-close with the ProGlide, and then we insert the wire, we carry on with the procedure, and then we close with the ProGlide at the end. Jens Erik, I'd like you to talk a little bit about your approach. I'm really impressed with your approach. It's a very sophisticated way of doing it. Would you want to talk about that?
Yes, I can do, Patrick, but you already gave us a fantastic demonstration of vascular access, and I agree. We don't want to have fistulas, we don't want to have pseudoaneurysms, we don't want to have hematomas. We want really safe vascular access, and the way to do that is to use ultrasound. And I use a slightly variation to your technique. I also start by having this transversal view of the femoral artery and the vein to the right, and then I sweep to a long axis view. And you can see on the left video, you can see the femoral artery bifurcation. And I sweep a little bit towards the midline, and you will get the femoral vein. If you start the video to the right, you will see the femoral vein, and you can typically here also see the entry of the great saphenous vein. And what I'm doing here, you can see it on ultrasound that I'm installing local anesthetic into the subcutaneous tissue to prepare for puncture. So if you take the left video, you can, having the transducer in a long axis view, you can easily see the tip, and you can see that I'm also, like Patrick described, entering the vein superior to the entry point for the great saphenous vein. And I totally agree to have the puncture sites over the femoral head. And to the right, you can see on the video just that the wire is inserted. And when you use an ICE-guided approach to PFO closure, you have to put in one sheath for delivery of the device and one sheath for the ICE catheter. We are using a long 20 centimeter long sheath for the ICE towards the midline, and more lateral we use the sheath for the device. And if you go to the next, maybe for the video, because you see the two sheaths here, one, the blue one for the ICE catheter, the yellow one for the device. And when we have finalized the procedure, instead of using two probe lights, I just make what I'm demonstrating here a figure of 8 suture. So with the needle and the suture, you make a engagement of the subcutaneous tissue. And then there's a little trick that I learned from an Irish cardiology colleague in Galway for a couple of years ago. Instead of tying a knot, you just take a 3-way tap here and hold it, and then you remove the sheath, and you just use the 3-way tap to have the suture tightened. And normally patients will lie with this for 2 hours, and then you can loosen or take away the suture. Just loosen the 3-way tap, and if there's no hemostasis at that time point, you can just tighten it again. So it's a very cheap and effective and flexible way to do vascular closure or hemostasis, I think. So
I really like it, Jens Erik. That's really fabulous. We've had a lot of questions online. I'm going to finish the section on vascular access and complications, and then we're going to go to some questions. Olivier, could you tell me a bit about how you close in Lausanne? How do you close veins?
Oh, I'm really sorry, because I think Jens Erik has a very cheap and elegant way to close it. And in Lausanne, we use a bit more expensive way. We put an angioseal on the right groin, because this is the way we insert the device. And on the left groin, we puncture for the eyes, and we put a second angioseal. So 2 angioseal, one on right, one on left. It works really well, but it's a little bit expensive.
Well, the great thing about these webinars is everyone learns. So we've learned a great bit from Jens Erik today. That's absolutely fabulous. We're talking about avoiding complication, guys. And, you know, we've already mentioned I personally give the heparin right at the start, as soon as puncture goes in, actually, even before I proglide, because clots from me, they can start from the start, and you just don't want to be having clots. So that's my approach to it. Does one of you, Jens Erik, tell us about de-airing sheaths and catheters, your approach to them? I'm sure it's very, very careful. Is there any tips you have for our people listening?
As you mentioned, we are doing a preventive closure, and we're going to prevent stroke. So air and clots are something that can actually cause stroke during the procedure. So we really need to avoid air and clots. So when you have big sheets, and we are entering actually the left atrium with a rather big sheet, it's very, very important that you have no air in it. And a very good way to de-air a sheet is always, when you place it there, take it underneath the heart level and let it backbleed. And that way you can get an effective de-airing of your sheath. And also, if you spend a little bit longer time with the sheath inside the left atrium, put a flush line on it so you have a continuous drip on the sheath. That's another way to avoid air. So that is very important.
I'll add a couple of comments on that, Jens Erik. Some of the devices don't have a valve on the end of the delivery sheath, and when you pull the trocar out or the dilator out, there's a possibility if you pull it out too quickly, particularly in a patient who might be awake, who takes a deep breath in, for air to be sucked in. And one way of avoiding air being sucked in is to pull the dilator out with the catheter immersed in water. And that approach works very nicely. And actually, when you do that approach, you often see quite a lot of air coming out. That's one approach. I think I just want to very briefly mention for audience what you do if you ever do get air. I hope you never encounter it, but you need to get the patient immediately head down because air will rise. And you need to hyperoxygenate, and you need to ensure that you are very, very adequately anticoagulated. And then you sit in that position as long as you can safely do so, and the air will slowly resorb. Of course, it does depend how much air has gone in. It's very frightening, and I hope it never occurs, but it's something that you need to know exactly what to do if it does occur. And of course, if it is a very large amount of air, the treatment is supposed to be hyperbaric oxygen, but of course, that's not exactly available very widely. Olivier, do you want to talk about the equipment that you need as bailout equipment? Say, for example, a very rare situation where your device is embolized. Do you want to talk a bit about snares and large sheaths, things that you need to have in your arsenal?
Yes, there are several devices, so they are all a little bit different. So the way to retrieve an embolized device is different regarding the brand that you have. The device can embolize on the right-hand side or on the left-hand side. So these are two types of complications. The one that I had, I have to confess, was embolized on the left side. So we were able to retrieve it from the artery, large artery, or in the ventricle. It can be frightened, and we have to be prepared for that. As you know, each time we go for cardiac intervention, we have to be prepared for complications. So the two things I think you mentioned, the one thing is large catheter is very helpful, because if you have to retrieve a device, you need larger device than the one you have, which is usually 8 to 10 French. So you have to increase your catheter. And the second is a snare. You have to be aware where is your snare in your shelves and how to use it. This has to be done before proceeding to a PFO closure. These are the two things that you were mentioning. I'm not adding a lot, but I think this is very clear that these two things are very important in order to retract a lost device.
I will add two comments to that, Olivier. One is that if you're using, well, most devices, whether they are the nitinol weave-based or the more open nitinol wires, they all have some form of hub to grab onto. And if you can get it by the hub, they will usually pull into a catheter more easily. If you grab it by a hub and it's not coming into the catheter in the way that you like, you can get a second snare on it to help with your alignment. That's a tip that sometimes can be helpful for these. But the bottom line is, if you're going to do a procedure, you need to know how to deal with the complications. You must know exactly where your snares are and exactly where your large sheaths are. I think that's a very important message. Okay, so if we bring up the last slide on this section. So in order to avoid, identify and treat complications, we would recommend echo imaging guidance during the procedure. Vascular access must be given great care and attention. It's probably the most likely cause of a complication in these patients. And we must, in my view, undertake it with ultrasound and give careful consideration to safe closure. I would recommend personally immediate and aggressive heparinization and a careful attention to detail to avoid air embolization. They must have a full understanding of the operation of the device and how it's retrieved and the emergency bailout equipment that you need for this. And we'll come on to post-procedure in just a minute. So Jens Erik, can you talk to me a bit about what your dual antiplatelet regime is for PFO closure patients? What do you use? Do you use dual antiplatelets? So how long do you recommend for? Are you interested in anything else? What do you use?
Yeah. Actually, I'm not, as a routine, using dual antiplatelet therapy. I'm using aspirin monotherapy, and we have used this for many years. I think we have probably performed more than 1,000 PFO and ASD closures, and our standards has been aspirin monotherapy, and we have had very few. 2 is the only cases I can remember of thrombosis on a PFO device. So I think that's quite a rare event. I don't think there's a lot of evidence for dual antiplatelet therapy. I think that's something that we more or less have imported from the coronary artery world. If you put in a stent, you have to use DAPT and more antiplatelet drugs. So I don't think we have evidence. And for me, aspirin monotherapy works quite well. Although I must admit that in a few rare cases, you can see that patient comes back after a PFO closure and they actually claim of a migraine-like symptoms, which is a little bit a paradox because, as you know, we have also interest whether PFO can help against migraine. But it's very clear that a few patients will get migraine-like symptoms after PFO closure. And there's some experience out there that clopidogrel is actually helping against that. And I must admit, in those patients that I've had with this symptom, I have given them clopidogrel, and they have had effect from that. So. But as a routine, our regimen is aspirin just 75 milligrams per day, and then they are preloaded. If they not come to the cath lab with aspirin on board, they are preloaded with 300 milligrams.
Olivier, can you briefly take us through your practice in antiplatelets post-procedure?
Yeah, I'm very pleased to hear that you can use aspirin alone. I didn't know. We are using DAPT. Indeed, this is coming from coronary artery disease, but still we are using 3 months of DAPT and then aspirin long term. So this is one thing. The other thing is, indeed, we didn't talk about the way to screen DVT, so deep vein thrombosis, which is indeed part of the process, but it can induce anticoagulation. And then if it's anticoagulation, we are not using antiplatelet therapy.
That's great. If we talk a bit about post-procedural imaging, in our lab, we do an echo. We do these as day cases. They go home the same day, and we have an echo pre-discharge. We like to do our post-procedural outpatient echo within 6 weeks, because in the rare event that you do get an embolization, I think it's much easier to remove the device with a wire early than late. So that's part of our process. We're running a little bit against time. Jens Erik, tell me a little bit about bubble echoes, when you do them, and how you act on the information you get.
Yeah, routinely we see patients 3 months after PFO closure, and we do a transthoracic echo, but also a bubble test. And my guess would be that 80% will have full closure when we see them after 3 months. And then there will be some patients where we see a few bubbles crossing the interatrial septum. And if we have good windows and can see that the device is in a good place, I mean, this is just a trivial finding. It's innocent. And it will go away with time, and we do know more. On the other hand, if we see a large amount of bubbles coming across the interatrial septum, we will proceed with TE, because then we will suspect that there might be an underlying problem. There might be a missed rim or some kind of displacement of the device.
So that's really clear. So you're actually using the bubble echo to see if there's a problem with the device, whether perhaps the anterior right atrial disc has slipped into the tunnel or something like that. So that's very good. I've got a lot of things online. We've got to turn our attention to some of these. So I'm going to answer some myself. Excuse me for looking down, but they're on my phone. And then I'll also put some to our panel. So where to start? So transcranial Doppler, a brief word in transcranial Doppler, Olivier. Is there a role for it in screening for PFOs?
I think bubble echo or trans brain bubble. I think all the things that you can use to prove that there is a passage of bubble through the PFO is helpful. So I wouldn't make an issue for that.
Fine. Jens Erik, do you have a role for thrombophilia screening in these patients, and what is it?
Yeah, we actually routinely screen for thrombophilia, and I think it's relevant because it might guide you to let the patient stay on anticoagulation. It will not prevent me from doing the PFO closure in most cases, because having a coagulation disorder, that means that you have a really increased risk of having a paradoxical embolism. So I'm in favor of closing PFOs, also if you have a coagulation disorder. And the same, you can have the same discussion for pulmonary embolism and venous thromboembolism. I mean, that is diseases that will increase the risk of a paradoxical embolism. And I think PFO closure are very much relevant for this group of patients as well.
Really clear message, Jens Erik. So actually, you're not doing it to persuade people that they don't need the PFO closure. They're going to get PFO closure plus stay on anticoagulation. That's a clear message there. Olivier, very briefly, closure of PFOs for people who have had embolic myocardial infarctions.
Yeah, we had actually several cases where we had really young patients with deep vein thrombosis and myocardial infarction. And I think this is a constellation which is exactly the same as a cryptogenic stroke. So we are closing that kind of patient. But again, I think we have to individualize clinical decision-making with patients, and it happens, definitely.
Yeah. And I would just add to that, Olivier, for me, I mean, there are many causes of troponin leaks. So you want a burden, personally, I think you want a burden of evidence for these patients. So you want to be pretty clear this is in the absence of any coronary artery disease. It's lovely to see an embolic filling defect in your coronary angiogram. In these young patients, you want to be sure it's not a coronary dissection, because that obviously can be an overlapping syndrome, at least angiographically speaking. And we would often look for a cardiac MRI scan to look for a typical signature of an infarction. Final question I'm going to answer online, because we're going to look to wrap up now, is antibiotic prophylaxis recommended procedurally? And for me, the answer is yes, we give it procedurally. So that's my answer to that. If we could bring up the final slide here. So I want to just really say a really big thank you to Jens Erik and also to Olivier for their real insight and expertise. And they've really managed to remove some of the mystery about working up these patients and the confusion that we have. I think you've given a very clear idea of the care we need to take in selecting these patients, but also in the care we need to take in the cath lab to make these a safe procedure. Our final key messages for those listening online: there should be very careful patient selection, and this really is the key to success. We need to take a multidisciplinary team approach with neurologists, imagers, and interventionists to be sure we have the correct patients in order to benefit from PFO closure. And I would encourage all of you who are interested in undertaking PFO closure to pursue a relentless attention to detail to ensure this is a complication-free procedure. My thanks once again to Jens Erik, and my thanks to Olivier for their great expertise. I'd like to thank PCR for putting this on today and for their organization. And of course, a thanks go to Gore for their unrestricted grant in supporting this particular webinar. There are many more PCR webinars for you to tune into and enjoy. And I wish you all an enjoyable rest of the day. Thank you indeed.